Hi, everybody. My name is Carson Hart. I'm the outgoing Chief Executive of Exceed Worldwide. I'd like to take a couple of minutes to introduce you to a program that we started exactly 10 years ago called the Exceed Research Network. I'd like to tell you a little bit about it and introduce you to some of the speakers who will follow me very shortly. We started the Exceed Research Network out of some frustration about the poor quality of research into the area of disability, especially in prosthetics and orthotics in low-income countries. We could see universities in wealthy countries with plenty of resources, but not really an understanding of the reality of life for a person in a developing country. And we decided that we would form a loose association, was in some ways more like an academic club, where like-minded people could get together and talk about research needs, and we could introduce people with research resources to people with research needs. So over the last 10 years, we have built up a substantial group of more than 30 organizations, all actively involved in research, and we have facilitated many programs across the divide between the wealthier and the poorer nations. We have tackled technology, tested new technology. We've looked at social and economic impact. We've looked at the durability and how long a device will last and when it needs to be replaced. We've looked at the impact of prosthetics and orthotics on growing children. And we've also worked very hard with the International Society for Prosthetics and Orthotics to develop ethical guidelines for the testing of new equipment on people in low-income countries. In the last year, one of our big successes is a publication that's about to hit the World Health Organization, looking at the outcomes of charity-based fitting camps where organizations will fit several hundred devices very quickly over a matter of weeks with little follow-up and little planning. And we're currently working on developing ethical guidelines on how we provide services, long-term, short-term, and in camps. It's been an exciting journey. The journey has just begun. The organization continues to evolve, but it lacks in structure, it lacks in constitution, it lacks in fee-paying membership, and in many ways that's its magic sauce. It's that affiliation of like-minded people mutually supporting each other. And we have made new friends, new colleagues, and we've inspired one another across the divide. And I hope and pray that Exceed Research Network will continue to drive forward the body of knowledge and make life better and better understood for people in the target countries in which we work. Enjoy the presentations. Thank you.
Hello, and thank you for the invitation to present at the Exceed Research Network 10th anniversary. Congratulations, by the way. My name is Cornelia Bard, and I'm gonna present a conceptual framework for the rehabilitation sector in fragile settings, the Rehabilitation in Conflict RIC framework. So there is a saying, the first victim of war is the health system. And indeed that signpost from Juba, South Sudan, says it all. Armed conflict is a health risk. Indeed, but before we move on, I would like to clarify what we talk about when we say conflict or conflict-affected countries, because it does mean acute armed conflict, but it's more than that. Conflict-affected can also mean contexts of protracted crisis, also post-conflict like Cambodia, and it also means contexts that are affected by regional conflicts, neighboring conflicts, through a large influx of refugees, which puts a burden on local health systems. Now, when we talk about rehabilitation in conflict, what characterizes rehabilitation in conflict? First of all, it's not that easy to understand rehabilitation in such contexts because they are usually very fragmented, there may be chaos, so it's actually difficult to grasp the rehab sector in such settings. What is also sure is that rehabilitation in conflict is underdeveloped, there's a lack of resources, rehab systems are overwhelmed, way too many needs than there are resources. Rehabilitation services in such settings are disrupted and they are fragmented and they are largely under-researched. Now, a conceptual framework can help to address all of these issues. It can help to better evaluate and understand the rehabilitation sector in such contexts. It can give guidance to strengthen and enhance rehabilitation services. It can also support the distribution of resources and their prioritization. A conceptual framework can also help to mitigate that disruption and that fragmentation we see in these settings. And it's very useful also to guide research. Now, we developed the RIG framework, and here on the right you find the link and the QR code to the original publication. I'm not going to go through the steps or the methods we used and the descriptions in detail. So have a look at the original paper. On the left side here on the slide, you see the framework, and you see it is composed of 4 different components. And now we're going to go through all of them with regard to understanding and strengthening rehabilitation in conflict. So the first and most important component of the framework is context. And it is the most important because it decides on the performance of all the other components. So context can mean a dense urban setting. It can also mean a very rural, remote, hilly setting. It can be a dry or a wet setting. But context is actually more than topography and geography. Context also includes the religions and belief systems, the traditions in certain contexts. It includes attitudes and perceptions and also history. So all of this included means the context, and all of these elements influence how rehabilitation is developed, how which populations need rehabilitation and how they can access it. Now, the second, also very important component of the RIG framework are the systems. And here we talk about a whole network of systems. So most importantly is the health system, rehabilitation as a part of health systems. But rehabilitation is actually distributed across different systems, and they all play a role on the rehabilitation sector. There is the economic system, the labor market, because work conditions of rehabilitation professionals, they play a huge role on how services are provided, or if they encourage people to leave the country or to stay. It also means what kind of work possibilities do people with disabilities have after having acquired the disability. Education systems are very important. We know that health literacy of populations clearly depends on their primary and secondary education. And also the quality of rehabilitation very much depends on primary, secondary education of workforce, but very clearly also on the availability and the quality of professional education. There are the legal systems. Here we are thinking of conventions of the rights of persons with disabilities, of children, of women, but also international humanitarian law and so forth. We must not forget the military system, because in many contexts where with an armed conflict on their territories, the combatants and soldiers are not treated within the health systems, but they are taken in charge in a military system, which is like a parallel structure to the health system, with their own treatment approaches and data collections. The social system, very clearly an important system for persons with disabilities and their participation in society. And then we have many other systems, including questions around sports, transportation, infrastructure. In many contexts, rehabilitation is closely linked to the non-governmental sector. There's also the informal sector that takes on a lot what is related to community-based rehabilitation, etc. And another important system, not to forget, is anything around indigenous traditions, wisdom. We have the private sector, particularly when we think about access to medication, but also assistive technology. An important player in rehabilitation in countries affected by conflict are international actors, and Exceed is one of them in Cambodia. We have the professional organizations, faith-based initiatives, so a whole web of systems that need to be taken into account in order to understand and develop rehabilitation. Now let's come to the population. The population in need of rehabilitation, maybe those who access rehabilitation and those who, for whichever reasons, don't have access. And here we need to look at many different objective factors as well as subjective factors. Very important: attitudes about rehab, beliefs, and outcomes on individual and population level with regards to rehabilitation are also part of the population component. And the last component are services, and this includes the workforce, rehabilitation specific workforce, but any other professional around the rehabilitation sector. It means the digital and physical infrastructure, regulations, guidelines, payment mechanisms are all part of the services component. Then the continuum of care, service flow, as well as leadership. Also, outcomes on the services level are part of this component, and the level of integration of rehabilitation within health, social, and other systems. So, what are the next steps? In our publication, we suggest pilot testing of the RIG framework, collecting field data to further develop and validate application tools. And we suggest a 3-step process of operationalization. First, describing the sector to guide informed decision-making for development, and to end in a 3rd step with an action plan to enhance rehabilitation in such settings. So I'd be glad to hear from you how you can use the framework, and here you have a few links. Do get in touch, and thank you very much.
Good morning or afternoon, wherever you are. thank you for taking the time to join us for this presentation. My name is Dr. Adam Manick. I am a lecturer in psychology at the Department of Health Psychology within the School of Population Health at the Royal College of Surgeons in Ireland. Today I'll be sharing some findings from our work on mental health screening and interventions for prosthetic and orthotic service users in Cambodia that we've been working on for the last number of years. This research sits at the intersection between disability service and mental health care and responds to an urgent need in the sense that persons with physical disability in Cambodia experience high levels of psychological distress, yet access to specialist support remains extremely limited. So our aim was to explore how culturally adapted, task-shifted mental health interventions embedded directly within prosthetic and orthotic services could reduce psychological stress, empower patients, and provide a safety net for those who had the most severe needs. So over the next few slides, I'm going to walk you through the context, the study design, the outcomes, and the implication for Cambodia's national mental health strategy. The Khmer rule of genocide left a devastating legacy in Cambodia. Between 1975 and 1979, an estimated 1.5 to 2 million people were killed and Cambodia's health and social care systems collapsed. Destruction was not only physical but also psychological. Families were torn apart, trust in institutions eroded, and collective trauma embedded across generations. The consequences remain profound. Poverty, violence, and addiction are widespread, and the intergenerational transmission of trauma continues to shape community life. Many survivors live with untreated post-traumatic stress, while younger generations inherit the social and economic instability that followed. Today, resources for mental health are still very limited. There are only around 60 psychiatrists serving the entire country, and most of these work in urban centres. Rural communities have been left without meaningful access to care, and traditional healing practice often fill the gap, though they cannot meet the scale of need. Persons with physical disabilities experience particularly high levels of psychological distress in Cambodia, compounded by stigma and absence of tailored support. International aid and local NGOs have made important contributions, but systemic challenges remain. Underfunded health infrastructure, limited training pathways for mental health professionals, and persistent social stigma around seeking care. These barriers mean that when services exist, they're often inaccessible or underutilised. This is the urgent context in which our work is situated, a landscape marked by historical trauma, ongoing scarcity, and a pressing need for inclusive, sustainable approaches to mental health and social support. We work to exceed worldwide to reach 465 prosthetic and orthotic service users across Cambodia. Each participant was screened for psychological distress using the K10, which is a widely used clinical tool and research instrument. Importantly, it's been translated and validated for use in Cambodia, making it a reliable instrument in this context. PTSD symptoms were also assessed with the PC-PTSD-5. We focus on adults aged 18 and over who score between 20 and 29 in the K10. This range indicates mild to moderate distress. Those scoring below 20 were considered likely to be well, while those scoring 30 or higher were excluded and referred to specialist mental health services. This process allowed us to target individuals with manageable levels of distress for our interventions, while safeguarding those with more severe needs by directing them to and referring to appropriate care with our partner organisation, mental health organisation that is. Our first intervention group that we developed to support the psychological stress, mild to moderate psychological stress in person with physical disabilities in Cambodia is the Friendship Group. So the Friendship Group is designed as a supportive community-based intervention. We deliberately chose the name Friendship Group to reduce stigma. In Cambodia, terms like mental health program can discourage participation. So framing it around friendship, peer support, and shared well-being created a culturally resonant and welcoming space. At its core, it's a peer support, psychoeducation and mindfulness group with behavioural activation activities set as homework to encourage daily practice and integration into everyday life. Importantly, we train prosthetists and orthotists to deliver these groups, embedding mental health care directly within disability service and extending reach beyond the very limited psychiatric workforce available in Cambodia. In our first study, of this particular package of studies, a non-randomized control trial was conducted with 72 participants. We found that participants in the group experienced significant reductions in psychological distress with moderate to large effects. Rumination also decreased, though with smaller effects. And importantly, PTSD PTSD symptoms and worry did not show significant change, highlighting both strengths and limitations of the intervention itself. Taken together, these findings show that the French group is both acceptable and beneficial, particularly for reducing distress, while also demonstrating the feasibility of task-shifting mental health care to prosthesis and orthotists in low-resource settings. Our second intervention is the mindfulness-based wellbeing program. This builds on my kind of own personal research background, in which I've developed interventions, mindfulness-based programs for healthcare professionals and the population they served. So, as part of this work, I developed the mindfulness-based wellbeing program, which is Buddhist informed and culturally adapted and resonant with Cambodian participants who engaged the program. The program drew on familiar concepts such as impermanence, compassion, and non-attachment, making it compatible with local traditions, and again with a focus of trying to reduce stigma around mental health in order to support engagement. And to ensure sustainability over time, I implemented a trainer model where I trained Cambodian clinical psychologists to deliver the program. This built local capacity ensured that the intervention could be embedded within disability services. In our study, which is kind of our first study on this particular intervention, we conducted a mixed method study using a quasi-experimental design with 18 participants and 14 controls. We found that there was large reductions in psychological distress in participants who completed the group worry and rumination, alongside significant increases in mindfulness mechanisms of action such as acceptance, non-reactivity, non-attachment, and non-aversion. The qualitative findings really brought these numbers to life. We interviewed all participants who engaged with the program, and they described feeling calmer, more resilient, and reported improved well-being, stronger relationship, and the adoption of daily self-care strategies. These voices show statistical changes translated into meaningful shifts in everyday experience. Together, the qualitative evidence highlight not only the potential effectiveness of the program, but also its Buddhist compatible focus, which made the intervention culturally relevant, resonant, acceptable, and impactful within the Cambodian participants who engaged with the program. This integrated model of care was embedded directly within Exceed's disability services, ensuring that mental health support was accessible in the same places where people already receive prosthetic and orthotic care. Delivery is task shifted, with trained facilitators extended reach far beyond the very limited workforce for mental health available in Cambodia. Participants were empowered by having a choice of intervention, which builds ownership and engagement with their own care. Cultural adaptation across both interventions was central. By using Buddhist informed framing and peer support, we reduced stigma and increased acceptability, making the interventions resonate with local traditions and values, which supported their engagement and accessibility. At a system level, the model aligns nicely with Cambodia's mental health strategic plan for 2023 to 2032, showing how this work contributes to national priorities. Importantly, it includes a safety net. The screening identified severe distress early and ensured referral to specialist support where needed with our partner mental health organisation. Finally, the model is both scalable and sustainable, offering a blueprint for other low-resource contexts and NMICs where specialist mental health services are limited. To conclude, our research shows that both the friendship groups and mindfulness-based wellbeing program are effective at reducing psychological distress amongst P&O service users in Cambodia. The friendship group findings strengthen the case for culturally adapted, task-shifted interventions in contexts where specialist care is scarce, while the mindfulness program demonstrated broad improvements across stress, worry, rumination, and mindfulness-based mechanisms of action that underpin positive health and well-being. Embedding screening within disability services provided tailored supports and a safety net for severe cases, ensuring that those most in need were identified early and referred to specialist care. At a system level, this integrated model aligns with Cambodia's mental health strategic plan, showing how research and practice can contribute directly to national priorities. Our model of care could be transferred to other low-resource contexts and NMICs with the correct cultural and structural adaptations, offering a pathway to close treatment gaps where specialist services are limited. We extend our deepest gratitude to Exceed Worldwide for their partnership and commitment to advancing disability mental health services in Cambodia. Also, our colleagues within the Exceed Research Network for their collaboration, insight, and shared dedication to rigorous, impactful research. and to the Swedish Research Council for their generous funding and support which made this work possible. Together, your contributions have enabled us to develop and evaluate innovative, culturally adapted models of care to strengthen well-being and resilience for some of the most vulnerable and marginalised people in the world. Many thanks. I'd just like to say thanks to you also for listening to this presentation, and just to give you my contact details in case you have any questions about the research. If you look up our names, my name is Dr. Alan Maddock or Professor Nera Ramstrand, you'll find a number of papers related to this particular research and some to come in future. So thank you.
Hello, my name is Thirat. Currently, I'm working with Exit Worldwide in Cambodia to support the sustainability of the prosthetic and orthopedic services in the countries by integrating the services into the healthcare system. Exit Worldwide is formerly a Cambodian trust and is an NGO based in the UK and has been working in Cambodia for more than 30 years. There are three major activities of Exit Worldwide: the prosthetic and orthopedic education that we have trained students to become a qualified clinician to fit artificial limb and brace for more than 30 countries. So the education program not only train the Cambodian student, but we also train the students from around the globe. We also have the prosthetic and orthopedic services that we provide assistive device to people with disability according to their need. And we have community program that focus on education, income generation to ensure that after mobility, the customer, the client can go back to live independent in the community. And the model of the services is charity support from donor. And firstly, it was set up to respond to the emergency need that come from the civil war in the countries. As a charity model, the biggest challenge is the sustainability. So it need to find a way to make sure that the services is sustained in the countries. So from 2014, Exit Worldwide has set up a social enterprise at the aim to get payment from private clients who willing to get a modern component or modern services, so they can pay for that services, so they don't need to go to other country, and also call recovery to get the contribution from the client who need the services to cover some part of the cost. So we get private client since 2014. Some funding flow into the charity. We also have agreement with the National Insurance Scheme for its member who need rehabilitation services as another big sources of fund. And this social enterprise model, it offers choice for the client who need the services for the modern component, that they don't need to go to Singapore, to other country to get the services, and also promote the quality of services for the clients. Charity model, the client might not complain about the quality of services as they get free of charge. So the social enterprise, it run like a business that the client will demand quality of services according to their payment. And at the same time, it promotes the services in the country as well as the profession. The profession has not been widely aware in the countries. And finally, without donor income or the donor become less support, we have enough fund to sustain the services. So it provide with the grant from the Australian Embassy in Cambodia, has expand the services into the healthcare system with the investment of the set up with the hospital. So the expanding into healthcare has aligned with the WHO guideline that rehabilitation is part of the healthcare system. the existing model, the rehabilitation currently is under the social affair, but it has expanded the services into the healthcare system to promote the client-centered approach that can provide early intervention for the client after the treatment in the hospital, and it promotes the continuity of care. So after medical intervention, the client can refer directly to the rehabilitation unit for the assistive device. And this responds to the emerged health condition of NCD such as diabetes, stroke, and traffic accident. So all the conditions, client will go to the hospital first. So with that hospital intervention, the doctor can provide the referral to the rehabilitation services early. And for the health financing benefit, as the services has been expanded into the healthcare, it also can attract different sources of funding. The funding from the Ministry of Health, supported by Health Equity Fund, the National Insurance Scheme support the healthcare treatment, and also a private client who need services in the hospital. So the rehabilitation will become a healthcare package, and at the same time it can cross-subsidize for those who cannot afford the services by themselves. So what do we do with our expansion of the services into the healthcare system? So we have set up the services at different hospitals. We have the services at National Petrov Hospital, at the Petrov Hospital. So these two is a national hospital, and we have the services at the private hospital, Central Hospital, and we are under negotiation with other national hospital. And we have services at one of the provincial hospital. So with all these services in the hospital, we have one central fabrication unit as a workshop to for the production, for the assembly, that will be sent delivered back to the hospital for fitting. So there is no space in the hospital for the workshop. So this allows us to be part of the clinical team, medical team, that we can join with the hospital continuum of care, and at the same time the services will be embedded into the hospital services. So as part of the sustainability model, we want PO services to be financed by the healthcare mechanism that support the services for the people who need assistive device. So an hospital-based PO unit that we have been integrated into the hospital. So the PO services can get financing within the healthcare system through Health Equity Fund, through the national insurance that could be cover the cost for the PO services in the hospital and make it sustainable. And this expansion of services is aligned with the policy document such as UHC roadmap in Cambodia that state that the rehabilitation is part of the healthcare system and need to be sustainable. The payment from the pocket is reduced. So with integration, the PO services is aligned with the national policy as well as the national protection policy framework that monitor these two mechanisms. Also work toward the update of the rehab benefit package to cover the assistive device. And at the same time, we also can get payment from client who willing to pay, who could afford to pay, and the cost will be contribute for those who could not afford. So with ICIT worldwide vision to expand the PO services into the healthcare system, it will align with the sustainability of the services, and also in terms of the clinical practice, it's aligned with the WHO guidelines. And for the funding that can be supported within these services, we can get the funding from Health Equity Fund, we can get the funding from the National Insurance, we can get the funding from the client who could afford, we can get the funding from the government to cover the extra cost, and also some funding from the donor. So all the sources of pool of fund will make the services sustainable. Thank you for your attention.
Hi, my name is Matt Thompson. I'm speaking today in my role at Stand and also drawing upon my work as a researcher across prosthetic service provision and assistive technology local production systems. That dual position shapes what I'll share. I'm not presenting a model or a set of solutions, but reflecting on tensions that we see recurring in practice, particularly around device sourcing and local production. Before going further, it's important to briefly situate Stand's role. While Stand is often associated with the refurbishment and redistribution of prosthetic components, that work sits within a much wider rehabilitation ecosystem. Our focus is not only on devices, but on fitting, follow-up, repair, and the conditions that allow prosthetic services to function over time. In partnership with rehabilitation centres and clinicians, we do community engagement, destigmatisation and policy change, because getting a prosthesis to someone is useless unless they wear it, are comfortable with it, and are empowered by it. So when I focus today on sourcing devices and local production, it's not because they are sufficient on their own, but because they're part of a much wider ecosystem, one where sustainability questions surface very clearly. I want to briefly describe the supply chain that Stand operates within, because it can be misunderstood as informal redistribution. Prosthetic components are collected from clinical settings across Europe and North America and Australia a little bit, but it's very far. Refurbished and quality checked centrally, and then they're redistributed to partner rehabilitation centres across East and West Africa. The viability of that model depends entirely on quality control. This question has been examined directly in a recent collaborative research involving ERN members. A study led by Michael, Louise, Lawrence and Vikrant, working with my colleague Promise, evaluated the impact of Stand inspection methodology on reused prosthetic feet. The study shows that structured quality control significantly increases the proportion of components that can be safely reused, and that common failure modes are identifiable rather than unpredictable. Importantly, this frames reuse not as an informal workaround, but as a technical and regulatory process that can be used to inform wider standard-setting discussions. The broader point is that reuse-based supply chains are only sustainable when they're treated as governed systems, not actual redistribution or donations. I want to talk about scale, not in the sense of impact figures and headlines, but because Stand works across multiple countries and maintains many long-term relationships with partner centres, we can generate routine service data over time and space. These dashboards help us see patterns: who accesses services, reasons for limb loss, how often devices need repair or replacement, and how needs vary by context. For instance, an elderly patient with a bilateral transfemoral amputation with a whole range of comorbidities, living in a rural area with no means for travel and lots of dependents, is going to have very different needs and provision challenges to a young guy playing amputee football for the national team in an urban centre who keeps calling us asking to get new running blades. In aggregate data, those can both appear as two data points labelled disability, but in practice they imply completely different sustainability and provision questions. Longitudinal view matters because prosthetic provision isn't a one-off event, it's a series of interactions over time, fittings, repair, adaptations, unevenly distributed across places and populations. I want to spend a moment on the tensions that emerge around device sourcing. On the technological side, we see an increased use of high-tech and proprietary components. They can offer functional benefits, but they have shorter lifespans, more complex repair pathways, and greater dependence on external supply chains, like microprocessor needs. We can't reasonably refurbish them and provide them to our centres partners. Carbon keel feet and cosmetic foot shells are increasingly common as well. They tend to wear faster than snatch feet and are less well aligned with local usage preferences, but we get given more. At the same time, supply remains heavily shaped by where components originate. In our case, the majority still come from the UK and the NHS. That concentration enables coordination, but it creates fragility. Services become exposed to funding cycles, policy shifts, and a small number of organisational bottlenecks. In short, there's a large dependency on very fragile parts of the supply chain. If there's 7 of us in the Stand UK team are in a car crash one day, then there's quite a few countries that will lose their main import of prosthetic components and P&O investment. Taken together, these aren't isolated issues, but interlocking tensions that shape what sustainability can realistically mean in practice. This uncomfortability around the dependency is why we talk a lot about the need for local production. Local production is where discussions can become hopeful but also difficult. Across contexts, we're seeing locally embedded manufacturing and innovation, from alternative materials to mobility solutions designed around everyday conditions. These initiatives matter because they respond to availability, environment, repair realities, and user priorities in ways imported technologies struggle to. At the same time, local production remains embedded within global systems of quality assurance, certification, accountability, most notably ISO standards, which play an important protective role for users. There are large-scale innovations from manufacturers like OSSA, which I learned about just today through the ERN, to global north startups receiving grants from places like 80-20-30, to small local projects like Chininga Mobility making wheelchairs out of bamboo in Uganda, to a friend and colleague, Eric Gabber from Ghana, who's now doing a postdoc in Brussels making prosthetic liners out of pineapple leaf fibres. The tension is that the same standards designed to ensure safety can also act as gatekeeping mechanisms, shaping what forms of innovation are recognised and supported. But at the same time, we repeatedly see examples of tests and trials which don't meet the right ethical standards in LMICs. The question isn't whether standards matter, of course they do, or whether ethics are important, of course there is. They are safeguards, but they're also barriers. We need to find a way to assist LMIC researchers in passing these barriers without it becoming completely walled off from them. I'll finish by stepping back from Stand. What this all points to is that sustainability in prosthetic services is rarely about choosing the right device or right product model, what type of knee or foot or 3D printed socket are we going to use. In practice, it's about who carries responsibility over time, dependency on international funding, local governments, And this is for repair, for coordination, for standards, and most importantly, I think, decision making. A lot of what we currently measure tells us what moved, how many feet are being used, but not why or who made the choices or what components have lasted long periods of time. For me, the real value of ERN is precisely in creating a space to examine these system interactions rather than resolving them too quickly into models or success stories for funders. Thank you.
Hello, my name is Alex Dickinson, and this presentation is as part of a collaboration between the Exceed Research Network, Exceed Cambodia, the University of Southampton, which addresses the theme in this 10th anniversary of the Exceed Research Network around ethical and appropriate use of routinely collected patient data and the kind of insights that we can learn from. Now, this presentation was presented at the ISPO World Congress in Stockholm in 2025 and was shortlisted amongst the top presentations for sustainability of prosthetic and orthotic service research. The title was Understanding Repair and Replacement of Prosthetic Limbs Using Routinely Collected Data. This is the funding behind the project, and there were no conflicts of interest for us to declare. It's well understood that the barriers to prosthetic and orthotic service are around affordability and trained professionals rather than purely inadequate devices themselves. And in Cambodia, we have a very large proportion of people who need prosthetic and orthotic or mobility assistive devices living in rural communities. So there is a clear health sustainability challenge towards universal health coverage, and we recognise that routinely collected data, which importantly has been collected in a standardised way, might let us to understand the changing needs or demands for prosthetic and orthotic care, identify groups who might be underserved by existing services, and then adapt them to make sure that we can support those people and justify ongoing funding. In the past, we published some work which looked at the demand for those services, looking across 50,000 records of prosthetic and orthotic service access over 4 decades. And we were able to see a large number of device deliveries, but also repairs across over nearly 7,000 clients. In this new study, we undertook what's called a Kaplan-Meier analysis of device survivorship, looking at endpoints of when the device might be maintained or repaired and when it might be replaced. And the purpose of this was to try and understand how long devices are lasting in normal service, and therefore identify which groups might be served particularly well or not so well by existing devices and services, and then potentially identify where we might improve that care. We were also able to look in quite some detail at the kinds of maintenance and repair which potentially would allow us to identify where device technical improvements could be made. The characteristics of the people across these 50,000 episodes of care were mainly people with lower limb absence and a great predominance for the transtibial and transfemoral level. They were mainly male. We distinguished between active clients and clients overall, so active clients being people who had accessed Exceed Cambodia services in the last 7 years, and therefore could be considered as not yet lost to follow up with regard to device repair, replacement, or maintenance. And that didn't really change with overall or active clients. And we saw a variety of ages and reasons for absence, so not purely weapon injury such as landmines or unexploded ordnance, as might in the past have been seen as the predominant reason for limb absence or amputation in Cambodia, but a growing prevalence and incidence of road traffic accidents and illness, which was primarily diabetes and vascular disease. We're able to look at over since 1994 up until the end of data collection at the end of 2019 that over 3/4 of devices recorded on the system had one or more repairs, and a variety of different kinds of repair or maintenance have been applied. So each of these colours represents a different kind of maintenance. These might be sort of short-term adjustments to socket shape or alignment, which might be part of the original fitting process or a first follow-up point. Then replacement of parts such as the straps or the cosmeses, and then eventually more structural replacement of parts like foot bolts and the foot itself. And we can already see information in this time series data reflecting the work that Exceed and the technicians at the centre had made to modify design in response to failures. So we can see around 2000 very clearly the predominant reason for repair and replacement being these sort of mauve-coloured strap suspension failures, and then replacement of straps with alternative suspension methods mean that this reduced over the following sort of 7 or 8 years down to very, very few strap replacements. Similarly, we identified a little burst of foot bolt failures between about 2009 to 12, and that was then anecdotally linked to a change in foot retaining nut supplier who used a different material device. When that was identified by Exceed, they then changed their foot bolt retaining nut material, and then that particular failure type reduced down again. So even before we start producing any data insights like this, we can already see the kind of benefits that had been made by Exceed by following their trends in repair and replacement. So we undertook the Kaplan-Meier survivorship analysis, which produces charts like this, where we can see the percentage of devices that survive before this endpoint, in this case of repair, or in this case of replacement, over time. And then these red lines indicate the median or the time point at which 50% of devices would be repaired or 50% of them would be replaced. So that median means repairs at 237 days and replacement at 727 days, which is approximately 2 years. We're able to look at those repair types in a little bit more detail, and we can see sort of 3 particular phases of maintenance and repair. So devices being fit initially in the first month, and then adjusted at the first standard follow-up around 6 months. Then suspension and cosmetic parts lasting a little longer but still being replaced within that first year, and then those structural components, median being replaced, so the foot in particular being replaced around about 1 year. Now these may be required device maintenance or repair events, or they might be opportunistic. So if the person is coming in anyway, there might be an opportunity to replace the strap, meaning that they can survive a little longer before needing a larger structural repair later on. As mentioned, we can then break this analysis down into different subgroups of client demographics as well. So this chart shows the difference in repair and replacement for different occupations or social roles, and we can see children and students having their devices repaired and replaced much more quickly or much younger, which may be adjustments as they grow and then replacements as they outgrow the device. And then, for example, farmers and labourers, the yellow and the grey line, having their devices replaced a little earlier than on the whole the other client demographics, as they're potentially wearing their devices harder. We saw later repairs and replacements actually for this dark blue line for the soldiers, but those are generally associated with people who had their repairs and replacements very early in this data set, when the physical rehab centres had less capacity perhaps to repair and replace. We also compared the 3 Exceed clinics, and each of these lines represents a different clinic, and we can see that there's a particular difference between the KS, the grey line, the Kampong Song clinic, as having their devices repaired later but replaced much sooner on average. And we ruled out that this was that this could be associated with the client's job being different in that centre, but we wondered whether instead it might be due to the environment on that coastal rural clinic and potentially their access to the physical rehab centre. So looking at the effects of the centre location, we can see the proportion of the clients attending the Kampong Song clinic being from these coastal regions with which there is a far higher annual precipitation, so much higher rainfall and also potentially more of a saline or salty environment, potentially rusting components out, compared to the other two centres which service primarily inland provinces within Cambodia. Now, those inland provinces may be more flood prone, so this chart shows the seasonal flooding in the Mekong Delta. However, this is seasonal as opposed to a very much sort of year-round annual precipitation rate for the Kampong Song clinic. Additionally, there's higher transport connectivity for those other two clinics, whereas the Kampong Song sort of catchment area has far less road connectivity. So the theory here could be that people are or the clinicians are choosing to repair and replace devices sooner for these clients because they know it'll be harder for them to get to the clinic for a repair. Alternatively, it might be that clients' devices are in worse shape by the time they do get to the clinic, and therefore the clinicians have no choice but to repair them. We also saw an interesting difference in gender, so women having their devices repaired and replaced sooner than men. And we ruled out the association between female occupations or roles being different, or the fact that the women in the centre, in the cohort were younger. It's possible they have better access or maybe more health-seeking behaviour, or it's also a possibility that the devices simply fit women's needs less well. We don't know, so I think all we can say at this point is that this reinforces the growing evidence base that we need to be considering equity of device care and service design for women. The clinical implications is that we may be identifying here some optimal time to repair or replacement. So a very worn and damaged device like this is actually a very good sign. This shows that the person got very good use out of their prosthetic and that they were able to wear it out. In fact, a late intervention, a late repair or replacement may be implying that the person has poor access to their physical rehab service. There are clear limitations that this only represents one country and it's only partial coverage of that one country, and we don't have any more information on people accessing other services for support, other clinics. However, we do provide benchmarks for maybe new service models that are proposed or new technologies. So from an engineering perspective, this is how long devices are seen to last, and therefore a quality measure alongside the service provision that engineers should aim for with new technologies. This aligns with the UN Sustainable Development Goals in terms of health and well-being, but also understanding and addressing inequities in access and ensuring that these devices can be repaired with local resources. We'd love to work with anybody interested on partnerships for the goals, Sustainable Development Goal 17. So please, if you have a digital record of a physical rehabilitation service that you run and you're interested to collaborate and undertake similar data analysis, we'd love to hear from you. So please do contact us. My email address is on this slide. You can access here the full paper that was published in the Journal of Global Health in 2025 on this study. And I'd be delighted to hear from you, and thank you for listening to our research.
Hello everyone, my name is Jan Andrusek, and I'm a professor and a researcher within Canada's largest children's rehabilitation hospital. At the hospital, I lead the Propel Lab, which focuses primarily on finding engineering solutions for some of the toughest challenges faced by children and adults with disabilities. Let me start with a simple truth. There are millions of people around the world who need prosthetic limbs, but do not have access to them. For many, limb loss results not only in physical challenges, but in lost independence, lost livelihoods, and lost opportunities. And while the numbers have improved since I first started my research some 20 years ago, they are still quite dismal. Some 80% of people with lower limb loss around the world still do not have access to highly effective standard of care that is a prosthesis. The reasons are painfully predictable. The cost of prosthetic provision is too high, there is a shortage of trained prosthetists, and devices that are provided are often poor quality and fail. There is, in fact, a pretty good paper that speaks to the barriers related to technologies for global health, and at a high level it summarizes them quite well. Barrier 1 relates to a technology that does not exist due to funding or scientific reasons. Barrier 2 is where a solution exists, but is not accessible due to high costs or some other implementation barriers. And barrier 3, where a technology is accessible but not adapted. This third one is important and quite interesting. As good as a technology may be, if it doesn't fit the cultural context, it is not a solution. We found that out the hard way in our work, assuming that function superseded cosmesis, when in some regions of the world it was the exact opposite. For many people, it was more important to ensure that the prosthesis looked natural so as to hide their disability, and walking function was secondary to that. The limited access to assistive technology, such as prosthetics, is often related to some combination of all three barriers. And as such, it should also be clear that addressing the huge gap in access to devices is not a technology problem alone. It is a global health inequity problem. A problem too big and too complex to be solved alone. And this is where partners such as ERN play an important role. ERN brings together research-focused professionals from around the world with the goal of benefiting people with disabilities by carrying out and applying high-quality research on disability issues. Developing technological solutions requires both advanced science and the grounding that comes from working closely on the ground and learning from the experiences of the people the technology is being designed for. Much of my work has focused on developing a prosthetic knee joint that is highly functional but at the same time simple. So simple equates to affordable, durable, and repairable. And high functioning is essential because most people who lack access to prosthetic devices are young, in the primes of their lives, and with the right assistive devices are capable of living fully independent and fulfilling lives. While a simple and effective solution is the goal, the way to achieve it requires science. To develop the concept of the knee, one that is both stable and smooth during walking, we relied extensively on advanced computational modeling, instrumented gait analysis, and structural testing. But this was only the beginning. Once you think you have designed a device that is safe and works well, it is time to put it to the real test. To get a complete and diverse perspective about how well the knee worked, and to further improve it, we conducted clinical field trials in 6 countries across 4 continents. Some of the first trials aimed to assess function and durability, while more recent trials focused on understanding the bigger picture in terms of quality of life, cost-effectiveness of prosthetic provision. Believe it or not, there is almost no scientific evidence generated to speak to the socio-economic benefits of prosthetic care, and specifically the provision of a high-quality prosthesis. While most of us working in the field clearly know that providing a prosthesis is life-changing and enabling, when funders or governments ask for the proof, there is very little to show. And therefore, it is not enough to develop better technology. It is imperative to use rigorous research to study the impact of technologies that already exist. Because deploying solutions that are well-intentioned but flawed can be more devastating than not doing anything. There are very important studies, many of them undertaken by ERN members, that have assessed outcomes related to how well and how long prosthetic devices serve their users. While many devices used in under-resourced regions work well and are durable and reliable, it has also come to light that there are prosthetic technologies that fail within weeks or months. Imagine the thing you rely on the most, the one that enables you to go to school or work or take care of yourself and your family. And that device fails, catastrophically, leaving you stranded with no alternative or means to get it fixed. This is a reality for many who are lucky enough to receive a prosthetic device in the first place. So while it is imperative to develop new technology, it is just as important to study the ones that already exist. Study them over the long term. So at the beginning I mentioned that my journey with the prosthetic knee joint has taken 2 decades, and perhaps now it is clear why. Progress in this field takes time because the goal is not just to build devices, it is to build solutions that genuinely improve lives, and that is work worth doing well.
Hello, my name is Amos Channon and I'm a member of the Exceed Research Network. I'm also a Professor of Global Health and Demography at the University of Southampton. This video is talking about a presentation that was given at the ISPO World Congress in Sweden in 2025. This demonstrates the work that the Exceed Research Network does. And it is a collaboration between members of Exceed and the University of Southampton as well. It relates to an evaluation of an intensive prosthetic limb fitting camp in Cambodia. And we think it demonstrates a lot about what the Exceed Research Network is about and demonstrates the benefit that it can have for users. Cambodia has a really great history of prosthetic and orthotic service development, but obviously access challenges still remain, especially for people living in rural communities, and how we can provide them with sustained care and device maintenance. Cambodia is an area where Exceed works and obviously are involved in the policy development in the country as well. There are lots of challenges which there are different solutions for. One solution that has been used in the past is something called missions or fitting camps, which basically serve a large number of people in a very intensive time, and usually give out prosthetics or orthotics devices over a very limited time with limited follow-up, but it means that people get devices that they may need. These are usually organised by international NGOs, and it's very different from the travelling services, the outreach services that are operated by local providers. ISPO themselves have raised the concerns about the quality and sustainability of the service model, because not much research has been done about the long-term effects of these intensive fitting camps. This research is about one such of these camps. So this was set up in March 2023 by an external NGO serving a region in the northwestern Cambodia. And in 2 weeks, they recruited over 600 clients in the area to give out mainly prosthetics. We were requested, sort of Exceed were requested by the Cambodian Mine Action and Victim Assistance Authority to assess the quality of delivered devices and the client satisfaction. This shows a real forward thinking by the authorities in Cambodia to try and understand the effect and the benefit of these missions. We're given approval by the camp organisers to perform the assessments that we've done, but not to intervene. So it's assessment rather than any intervention. So how was this study conducted? After getting the appropriate ethics approval in Cambodia, there were 2 stages to the data collection. All of them were done by a team of experienced ISPO certified prosthetists. There was a standard device assessment at delivery. So when the individuals were leaving the camp, the device that they were given was assessed by this team of prosthetists. This was to assess fit and satisfaction, and there was some qualitative comments made by the individuals as well. Followed up by, in 3 months, there was a telephone interview, and that looked about how the use of these devices was going. So how many times they used it each week, the device status, how it was, and their preferences for future devices too. The data that was collected was analysed by a team of 3 researchers who are completely independent from the collection. This is to try and separate the collection and analysis, so an unbiased view was taken. Further ethical approval was obtained. The questionnaire responses were coded and made sure that there was good quality of data, and we analysed them for the whole group and also in subgroups according to their device status. We also performed content analysis of free text comments. So what were the results? So a brief overview was that in the fitting camp, 525 clients were interviewed. They'd all been given a prosthetic device and completed stage 1 of the research, so the initial assessment. Some key characteristics are on the slide now. Most of the clients were within the older adult range, so the interquartile range was between 54 and 64 with an average age of 59, and very predominantly with a lower limb absence due to weapon injury. They were mainly male as well. These characteristics were expected owing to the primary route of recruitment from the veterans community for these missions. The older group were seen to be more weapon injury, but the younger had more road traffic accidents or illnesses. %84 of these 525 people who were interviewed were established prosthesis users. And the median time since they had a previous device was about 5 years. While their status of the old device was not reported for about a third of the group, but 39% of those who did have a previous device said that it was broken, damaged, old, or just poorly fitting. However, a quarter of the people who actually had a new limb given to them said their previous device was in still good condition. Obviously, there was not an assessment of whether the previous device was in good condition or not. This is the reporting by the individuals. In the device quality and satisfaction assessments, this is the assessment of the device that had been given to them. A large majority of these devices were observed to have poor workmanship, fit, function, or cosmesis. Nearly 2/3 of the clients, immediately after being given the device, were asked to keep their old device. The tool that we used is not actually validated academically, but it is very close to the device checkout form used nationwide in Cambodia in physical rehabilitation centres and the ISPO and ISO 9001 certified P&O school. And devices failing to meet any of these checks at delivery in a standard setting would be reworked, especially those criteria which might lead to poor function or potential injury. Hence, we were surprised about how poor these elements were immediately after delivery. The content analysis of the interviews aligned with these assessments, with many comments about gait deviation, leg length, misalignment and poor socket fit, as shown in these representative photos. Hence, we were concerned about the quality of the devices that were given. So what happened after 3 months? We managed to follow up 2/3 of the clients at 3 months. And over half of these reported discomfort, damage or disuse of their new device. The majority preferred their previous device. Indeed, only 1 in 5 of the people who were given a new device was often or always using their new device. I say, of those who could compare, 78% preferred their previous device, and 80% could walk further in it. These are low figures given the cost of these fitting camps as well. %87% of the people we followed up had actually reverted to using their previous device. Breaking this down by the device status previously about how good it was, a large proportion of people who described their previous devices as broken, damaged or poorly fitting or even worn out were using their devices. You can see from this graph here that how people on the left-hand side about their previous device, how they used it in the second follow-up. So a number of people who had broken, damaged or worn out always used their previously described poor device. The quality and satisfaction of devices delivered in these camps fell short of ISPO Divine quality criteria, and over a quarter of clients overall had reverted to using an old device, which may clearly place them at risk. The study raises questions about client selection and whether the camp was an effective use of funding. Though the average age of previous devices was quite high at 5 years, many clients had devices less than 1 year old, and a quarter were in good condition, yet they were given a new device. So, what does this mean? In 2004, concerns were reported about these devices, about the efficacy and the quality of them given out in this manner. And our study within the Exceed Research Network suggests that these quality and satisfaction issues may persist. Our study raises new queries about intensive camps for device provision and whether adequate follow-up care is in place, especially because this camp was not integrated with existing services and device technologies. Inadequacies in training and follow-up care may have widespread consequences of burdening local physical rehabilitation services if they exist, or if they have low capacity, they will overburden them further. Alternatively, or as well, they can leave vulnerable clients without support, especially in this scenario where the camp was delivered in a format and with devices that do not integrate with the currently available services. Camps may be more appropriate when need is clearly demonstrated, and they should be integrated with the existing services. Also, they should leave behind adequate materials and components for repairs and replacement. Screening of patients for need is essential, as is engagement of the practitioners who will be expected to continue with their care. Thank you for listening. If you'd like to read more about the study, this is going to be published in the Bulletin of the World Health Organization. And we feel that it is a really good example of collaborative work to highlight an issue that is of concern. Thank you very much.
Hi everyone, my name is Caitlin Edgar. I'm a researcher from Imperial College London, and alongside my colleague Claudia Giardini, we love to share our work, which we conducted in collaboration with the Exceed Research Network. Our work focuses on children with lower limb loss in low resource environments. So what are we doing as part of our Exceed Research Network collaboration? Well, we're working alongside the Cambodian Department of Prosthetics and Orthotics. Cambodia forms a lower middle income country and therefore forms one of our lower resource environments. And specifically there, we're working to understand the needs of children who are a growing population both in number due to the increase in conflicts globally, but also, of course, they are growing both physically and developmentally throughout their childhood. So they pose a very complex rehabilitation challenge. And specifically, we're looking at children with lower limb loss or absence. So this could incorporate multiple levels of amputation or absence. But what these have in common is that they require a prosthetic limb as part of their rehabilitation process. So why are prosthetic limbs such a critical intervention for children? Well, first and foremost, they return mobility and independence after amputation. But secondly, they also allow children to safely reintegrate into communities and education. Sadly, disability stigma is still quite prominent in low-resource environments, as highlighted here by a teenager in Cambodia who did not want people to recognise they were an amputee. In order for us to support this wish, we must ensure prosthetic access. But thirdly, children are still growing and developing, and so therefore their prosthetics must support this with healthy physical movements, otherwise we can end up with secondary musculoskeletal complications such as this lower back issue in this young child. Therefore, appropriate prosthetic access is essential. Sadly though, there's been very limited research and innovation or design change in prosthetic limbs in low resource environments for children for many years, and as a result we're struggling to provide a full life beyond limb loss for this cohort, and this is something that we want to change through research. So what are our research goals? Well, all our research goals fall under the requirement to identify the user needs for children. So what is it that they want from their prosthetic limbs? What do they need from their prosthetic limbs in order for them to thrive as a child throughout their childhood? In order for us to look and understand this, we had three key aims. One was to define the cohort and their challenges, and we did this by looking back at clinical case files kept by the Department of Prosthetics and Orthotics in Cambodia for many, many years, 72 of them. Then we asked ourselves, how can we engage children and key stakeholders to listen to them, learn from them, and allow them to call for actionable change? To do this, we created a novel research toolkit in collaboration with the Centre. And finally, we applied this toolkit to identify the user needs for children with 16 families in Cambodia and 6 prosthetists. So I'm going to dive into some results now. So under this umbrella of defining the cohort and their key challenges, we first looked at who was coming to the centre and why. So we found, first of all, that 59% of children had acquired their amputation due to traumatic reasons, and that 68% of the children attending the centre were male, and that 55% of them had their amputation below the knee at the transtibial level. So once we had this kind of cohort information, we then dived into in-depth clinical notes that were kept for every single visit at the centres. And what we found from this was that the main reasons children were coming back to the centre was that they were growing and developing as expected. And this affected transtibial and knee disarticulation children the most. However, for transfemoral children, what we found was that there was also a severe issue with the suspension system or the Silesian belt, which caused them to come back with greater frequency. So we began to get a bit of the picture of the challenges that children were facing during their prosthetic access. So we then use this information from the clinical case files to dive into each challenge specifically. If we first look at growth, we can have two different major types of growth issues. One is a socket fit issue, which is when the residual limb continues to outgrow the rigid socket around it, or a prosthetic length discrepancy issue, which is when the intact, uninjured limb continues to grow, but the prosthetic limb does not. And what we found when we looked at the results was that prosthetic leg discrepancy was a universal problem across amputation levels, which is to be expected as it is primarily dependent on the intact limb's growth. However, what we did find was that socket tightness was a much more significant issue for transtibial and knee disarticulation limb absence levels, which may be explained by the variation in growth plate status between these amputation levels. And I would encourage you to look at the full results here, which explains it further. Taking the second major challenge, which was durability challenges, what we actually found when we looked at the individual technologies reported in the case files was that sadly, donated componentry from high-resource environments was causing much more significant durability challenges than the standard locally manufactured component. And this may be because donated components are not designed for the intended environments, and as a result can be causing children to come back to the clinic much more often than required. And so we should really be supporting local manufacturing initiatives globally. Another area that we were able to look at with the clinical case files was residual limb health, which is a key critical point for rehabilitation. And what we actually found was there was difference between residual limb health conditions for different amputation levels. For instance, if you take bone overgrowth, which is a really challenging problem for children, we found that actually it was only the transtibial limb absence level that was affected. If you then, in contrast, if you take a different residual limb health condition, excessive soft tissue, it was actually primarily affecting the transfemoral limb absence level. And so we really need to watch out for different residual limb health conditions depending on amputation level. Furthermore, what we also found was that socket fit negatively influenced residual limb health conditions. As we can see here, wounds and calluses were more likely to occur when there were socket fit issues. So we really need to be monitoring socket fit proactively. So now we had begun to get a bit of a picture of what the cohort of children was in Cambodia. We then wanted to engage them directly and ask them exactly what they wanted to change or what they liked and didn't like about their prosthetics. To do that, we created a novel user needs research toolkit, which covered 4 domains: prosthetic design, functional mobility, quality of life, pain and physical health. And this actually engaged both the child, the parent or guardian, and the prosthetist. And this is all available open source, so please check it out. What was key about it during the development process was we wanted it to be fun and engaging. So we used card games in order to distill key criteria that were important to children. We also did objective functional movement tests in order to match up what they said they wanted with how they were actually achieving tasks physically. For the other domains, we used the PEDS-QL prompts for quality of life, which were easy to understand, already validated and available in Khmer, and asked children to rate different aspects of their life on a scale. Then we also used their pain questionnaire, which allowed children to rate their pain and also colour in a visually appropriate physical representation where they had pain and grade it according to how painful it was. And finally, we also used the socket comfort questionnaire to rate how comfortable their prosthetic was. So who were the children that we managed to recruit? Well, we recruited 16 children, which was fantastic, with a mean age of 13 years. There was a lot more males than females, as to be expected from that initial demographic analysis. The majority were unilateral, and we had a good even split between below knee and above knee, which allowed us to look at different prosthetic componentries. And similarly to the demographics, we found that the majority of our children presented with traumatic amputation. On to some of our key findings. Well, from our qualitative interviews to look at prosthetic design, children told us that they had issues with stability with their knee joints. So for instance, they said they couldn't always control their knee joint, resulting in falls. And additionally, they highlighted issues with walking speed. In contrast, parents highlighted the issues around disability stigma and the fact that their child did not always want individuals to see that they had a limb absence. In contrast, again, the prosthetist highlighted that actually a major issue was that there wasn't enough sufficiently small componentry to fit the youngest kids. For the functional movement analysis, what we found was that the functional movement actually matched up well with what children ranked as high priorities within the card games in the interviews. And one key area to consider was the importance of cultural activities such as kneeling to pray and to play. Children really struggled to kneel, and they highlighted it as a key area for change in their priority cards. So quality of life, one key result we found was that actually children who were attending a school for children with disabilities self-reported the best quality of life compared to children in general school and in no school. And this really highlights the importance of educational and peer-to-peer support for key quality of life. One other major challenge which we found when we associated the psychosocial quality of life scores with pain was that increasing pain was causing a decrease in quality of life, as would be expected. And so we must really look at targeted pain interventions to improve health-related quality of life. Looking at where that pain actually occurred, well, it differed for children with below knee and above through knee limb absence, but the aspect of in common was the fact that they had pain both in their residual limbs, but also already in secondary musculoskeletal locations, such as the lower back and intact hip and intact knee. And this is of severe concern given that these children are going to be lifelong prosthetic limb users. So we gained a huge amount of information, and I've barely touched on all of those different aspects in this video. Just wanted to give you a flavour of what we did. But how did we bring it all together? Well, we tried to make what we called a hierarchy of user needs, and I'm showing here the one that we created specifically for prosthetic knee design, where we took inspiration from Maslow's hierarchy of needs, placing the most important parts on the bottom of the pyramid and looking at each user individually. And we can see here how these users differ significantly. But what this provides us with overall is it allows us to help engineers include the essentials within their prosthetic limb design for children. So a whistle-stop tour through our absolutely amazing collaboration with the Cambodian Department of Prosthetics and Orthotics. And we just want to say thank you so much to the incredible teams, everyone at the Exceed Research Network, Cicely and Carson, and of course all of the prosthetists that collected the data and taught us everything that we have presented here today. And yeah, we look forward to sharing our results formally through publications, but please get in touch if you have any questions. And we're always going to be here working to improve prosthetic limb design for children. Thank you.
Hi, and welcome to this Exceed Research Network's 10th Anniversary Forum. My name is Nachi Chokalingam. First, I'd like to thank Carson and Sam for everything you've done to coordinate this research network over the years. My closing thoughts from a series of presentations you've just heard are gathered under the title Joining Forces for Better Lives. I have to say, I can't quite believe that it's been 10 years. In that time, obviously, we have built evidence, us network, we have trained colleagues, formed friendships, and supported services in very difficult contexts. But we all know that there's still a long way to go. Many millions of people live with limb loss, and most of those in lower income settings. They still do not have access to prosthetic, orthotic, or rehabilitation services. Having said that, the good news is that this dedicated, collegiate group of researchers, clinicians, and some of us policymakers contributing to policy development is exactly the right group to make the next decade count. That's what I meant by joining forces for better lives. Listening to all the presentations so far today, it's reminded me very clearly why networks like this really matter. We began with Cornelia, who set out a powerful conceptual framework for rehabilitation services in conflict-torn regions. She showed that rehabilitation in these settings is never just about devices or clinics. It's about systems disrupted by conflict or war, communities under strain, and people whose lives have been turned upside down. That frame helps us to see why our work has to link with clinical care, policy, mental health, social support, rather than treating these from separate viewpoints. We then visited two topics that many of you would remember from earlier work, but which will remain central to both for Exceed and the wider sector. The first was understanding repair and replacement of prosthetic limbs using routinely collected data. And the second was the quality and satisfaction evaluation of an intensive limb fitting camp in Cambodia. Together, they've shown how much we can learn and when we treat service data as a shared resource. And when we look at critically at this data and the models of care, that can appear attractive because they are intensive and visible, but raise questions about follow-up, sustainability, and fit with the local systems. That's important to me and to the wider context. We also heard about pediatric prosthetic provision with clear focus on user needs. And as I've always said, and some of you might have heard me speaking about it, children are not just small adults. If we listen carefully to children and families, we start to design services that fit around school, play, participation in the society, rather than simply shrinking adult devices to fit a child. Then Jan took us into the question of appropriate assistive technology in low resource settings. He reminded us that a device that looks impressive in a lab or in a high income clinic may be completely inappropriate on unpaved roads, for example, or in heavy rain or in very hot conditions. His examples of translational research showed why it matters to test and adapt technology in these settings where people actually live and do that work together with local clinicians and users. Mental health and disability ran as a strong thread throughout this session. On the presentation on mental health screening and intervention for P&O service users in Cambodia showed the culturally appropriate, sustainable mental health support is possible even where specialist services are scarce. If we build on local strengths and train existing workforce, we can achieve what's been achieved in Cambodia. Another presentation from Cambodia focused on the developing sustainable rehabilitation services from a national context. It reminded us that it's one thing to show at a camp or a mission or a new technology that can work once. However, it's another thing to embed that work in national systems with local ownership, local training pathways, and reliable funding pathways. Matt then picked up this theme from the perspective of Stand. He spoke about device sourcing, local production, holistic rehabilitation. For me, that reminded us that for users, the device, the therapy, the community, and the wider environment all sit together as one experience. The other thing I'd like to say here is ethical approaches to research and practice sits underneath everything we have heard in these presentations. As a network, we have already shown leadership in this area in conjunction with ISPO, International Society of Prosthetics and Orthotics. Exceed was instrumental in developing and presenting the position paper on ethical considerations and approaches for conducting clinical research studies related to P&O and wheelchair technologies in low and middle income countries. That work set out practical guidance for partnerships, consent, data use, and for benefit sharing. It reminds us that how we do research and how we work with service users is just as important as the research questions we choose to study. If you step back and look at this program as a whole, a pattern appears. We've talked about conflict and peacetime, adults and children, mental health, physical function, technology, data, training and service models. On the surface, these are very different topics. Underneath, they're all asking the same question. How do we build prosthetics, orthotics, and rehabilitation systems that are context sensitive, ethically grounded, and centered on the rights of people who use them? That's exactly the question that this research network and a group of us have been working on in the background through a new position paper that we are now preparing to publish. It's called Global Prosthetics and Orthotics, a position paper on systems, context, and collaborative process. In that paper, we bring together much of the evidence and many of the ideas that's come out of Exceed Research Network. and related collaborations over the last decade. We look at education and training, service provision, advances in technology, global initiatives and organizations, and the role of interdisciplinary collaboration, along with the influence of local context and culture. We also have tried to address trade barriers, regulatory issues, and the environmental impact of what we do. The central argument of the paper is very simple. If we want to close the enormous gap in access to prosthetics and orthotics, especially in low and middle income countries, we have to move beyond device-centered projects and short-term missions. We need to think and act at a system level. This means investing in local training, in national service models, in data systems, and in the relationships that make this kind of collaboration possible. It also means recognizing that good solutions will look at different places because of culture, history, geography, and politics all shape what is possible. We are now taking this paper through publications and we'll be sharing it with you in the coming months. I hope you will see it as a collective product of this network. Use it within your teaching, your advocacy, and your conversations with funders, policymakers, and help us turn its recommendations into concrete action. So, as we look ahead into the next 10 years, I want to leave you with three brief reflections. First, multidisciplinarity. It's not a luxury. It's essential. None of us working alone can see a full pathway from decision in a ministry or a company through the moment when a person takes their first steps on a new prosthesis. Imagine that. We need each other. We need to keep building teams that cross disciplines and borders, and that include people with lived experience as equal partners. I'm a big fan of that, and we need to make sure that our service users and patients are part of what we tend to do. The second, the context and culture, they're not side notes, they're central again. The work that we have heard about in Cambodia, in conflict settings, and in pediatric services all shows that when we take local realities seriously, our interventions change. It also means that the outcome measures can be adapted and our service models can be reshaped. The third, data on stories matter. We need quantitative evidence on outcomes, repair and replacement, cost and coverage. At the same time, we need qualitative work that captures how people experience these devices and the services in their daily lives. Our position paper argues strongly for this combination of rigor and relevance. Let me finish by coming back to our theme. For me, the message of today is very clear. We will only make real progress if we continue joining forces for better lives. Better lives for people living with limb loss and limb difference. Better lives for their families and communities. And better systems that are fairer, more sustainable, more responsive to what people actually need. Thank you for your commitment, your honesty, and your collaboration. I wish Exceed Research Network continues for a long time to come. And I'm very much looking forward to what we can achieve together in the next 10 years. Please get in touch with any of the people who are presented in this forum, or Sam, Carson, or anyone in Exceed Research Network, and we'd be more than happy to help, contribute, and to help you in whatever way we can. Thank you.